to listen to Sherwin Criseno, who is a consultant nurse in endocrinology at University Hospitals Birmingham and is also a volunteer member of our medical committee. And as we were talking just before opening the call, I said to Sherwin, I understand you lead the largest team of specialist nurses in endocrinology in the UK. He put me right and said, actually, it's in Europe, across Europe. So big team, a lot of specialist knowledge there. And we're really delighted, Sherwin, that you've given up your time tonight to talk to us about growth hormone. So over to you.
Thank you very much, Emma. And thank you, Easy, as well. Thank you to the Pituitary Foundation for the invitation. And thank you for all who are joining us on this nice sunny Thursday afternoon to learn about growth hormone. So what I'm going to be presenting in the next 25 minutes or 30 minutes is really the current landscape, what we're currently doing in terms of both assessing, diagnosing, and also managing patients with growth hormone deficiency, because things have moved on in the last 20, 25 years in terms of the growth hormone field. And it's nice to know really from your perspective, who are the group of patients that we are targeting and who among the patients who are likely to have growth hormone deficiency would benefit from treatment. So for today's session, some reason my slides are not, there you go. So we will be talking about who we should be testing for growth hormone deficiency. We're going to be talking about what tests we usually use in clinical practice for diagnosing growth hormone deficiency. And throughout my presentation, if you've seen the acronym GHD, that means growth hormone deficiency. Who we should be treating with recombinant human growth hormone treatment, and why we should be offering treatment to those patients who are eligible for treatment, and what are the treatments currently available, and what are the new treatments that are coming in the market and also been introduced in the market in the last few years. And lastly, we're going to be talking about how patients should be treated and how patients should be monitored once they are on growth hormone treatment. So let's start with the first question, who we should be treating, who should be testing for growth hormone deficiency. And this is very, very important. There is an international guidelines that clearly outlining who we should be offering testing for growth hormone deficiency. We cannot be testing everyone, and we cannot be testing every single patient who thinks that they have growth hormone deficiency. And there's several reasons for that. And most of those reasons I'll be touching on in my presentations. One of the main reason is because of the test that we use. There is no single test that is 100% accurate and 100% sensitive. Majority of the tests that we use, or most of the tests that we use, are not 100% accurate nor 100% sensitive in diagnosing growth hormone deficiency. We will always get a false positive and false negative, meaning we will always get patients who actually don't have growth hormone deficiency that tested positive from the test, or those with growth hormone deficiency that the test shows that they didn't have growth hormone deficiency. So it is very important that the first rule in testing is that there should be a clear suspicion that these patients probably have growth hormone deficiency. So there should be a clear and high suspicions of growth hormone deficiency on that patient. And where is that suspicion coming from? From the patient history. For example, patients with organic disease that likely will cause growth hormone deficiency. For example, those patients with septo-optic dysplasia, craniopharyngioma, for example, who had surgery that affected or in some degree damaged significant part of the pituitary glands. Because once you damage a pituitary gland, it's likely there's a higher chance of the growth hormone producing cells in the pituitary gland that will be damaged as well. And what is the proof of that? Okay, majority of the patients where the pituitary gland has been damaged during surgery or by a medical condition will end up having multiple hormone deficiency. We call them panhypopit. So where the patients have 3 or more hormone deficiency and they're being replaced for that deficiency. If we're going to look at this graph shows you if your patients got 3 or more hormone deficiency, the chances of them having growth hormone deficiency as well is around higher than 90%. And in this group of patients, we no longer need to use, or we no longer need to subject the patient to a very complex test, because the likelihood is that patient will fail the test and tell us that the patient has growth hormone deficiency. We only need a simple blood test such as IGF-1, which is insulin growth factor 1. If the patient's got 3 or more hormone deficiency and the IGF-1 is low, we don't need any other tests, because that's already an indication that that patient's got growth hormone deficiency. For a patient with at least 1 or 2 pituitary hormone, we're talking about pituitary hormone, the hormone produced from the pituitary gland. If 1 to 2 of those pituitary hormones are already low in that patient, the chances of them having growth hormone deficiency is higher than 80%. But those without growth hormone deficiency, without pituitary hormone deficiency, the chances of them having growth hormone deficiency is less than 40%. So this group of patients, particularly those with 3 or more hormone deficiency, are those group of patients that we don't need to test anymore. But those with no or up to 2 pituitary hormone deficiency, they still need to be tested to confirm whether they have growth hormone deficiency. So the second group of patients are those with history of tumor, either a tumor in the brain, tumor in the pituitary gland, or those with history of arachnoid subhemorrhage, or those patients with history of traumatic brain injury. We need to test those patients. So let's start with patients with pituitary tumor, okay? If you have a tumor in your pituitary gland, that tumor will cause what we call a mass effect, meaning it will exert pressure to the normal pituitary gland. And that continuous pressure, if that tumor is not removed, that pressure in the pituitary gland can damage or prevent the pituitary gland from producing hormones. And one of that is growth hormone. If you're going to look at this illustration here, from the pituitary tumor alone, without any surgery, without any treatment, the pituitary tumor alone can cause growth hormone deficiency, and the growth hormone is the first hormone that will fail, followed by the gonadotropin, which is the LH and FSH. These are the hormones that regulate the testosterone and sperm production in men, and the estrogen and the egg production in women. And then the last hormone that usually fail from the mass effect, from the pressure from the tumor, is usually the hormone that regulates the thyroid hormone, and also the hormone that regulates the cortisol. It's the growth hormone that fails first. However, we don't replace the growth hormone first if the other hormone hasn't failed yet, because the growth hormone is not a critical hormone for survival. What does that mean? We will survive or live as adults without growth hormone. So we don't replace that yet, because there's no evidence that that will improve mortality or that will improve your quality of life if all the other hormones remain intact. So if we're going to look at those patients with radiotherapy, for example, if they had radiotherapy because of the brain tumor, not because of pituitary tumor, they have a brain tumor and they had radiotherapy. The radiotherapy also can cause growth hormone deficiency. However, we need to remember that the data on the effect of radiotherapy to the growth hormone productions were from many years ago, wherein we use conventional radiotherapy. When we talk about conventional radiotherapy, these are non-targeted radiotherapy. So about 15, 20 years ago, when the patient's got a brain tumor, for example, not necessarily in the pituitary gland, the whole of the brain will be exposed to the radiation. So meaning even the pituitary gland will be exposed to radiation. And therefore, one of the effects of radiation is they shrink the cells, and eventually those cells die. And if the patient's got a brain tumor, the collateral effect of the radiation to the pituitary gland will eventually cause growth hormone deficiency, because the part of the pituitary gland that's been exposed to that collateral radiations will then shrink, and eventually they will no longer produce growth hormone. However, the cells in the pituitary gland responsible for producing growth hormone are quite sensitive to radiation, even at a low dose. So the radiation, the dose of the radiation is measured in what we call gray. Even at a low dose of 18 gray, growth hormone deficiency can occur following that radiation. And the higher the dose of the radiation, the greater the chance of patients developing growth hormone deficiency. And if, for example, in patients who would receive radiation of a dose of greater than 30 gray, for example, 45 to 100% of those patients will end up having growth hormone deficient. However, remember that this data were from patients who were exposed to non-targeted radiotherapy many years ago. We're now using targeted radiotherapy such as Cybernat and SRS, and the collateral damage to the surrounding tissue, particularly if it is not the pituitary gland that is being targeted by the radiotherapy, is minimal. We don't have data yet, though, regarding what is the incidence of growth hormone deficiency using targeted radiotherapy if the target radiation is not directly the pituitary gland. But what we know based on evidence and based on what we've been seeing in clinical practice, we are diagnosing fewer and fewer growth hormone deficient patients who were exposed to those type of targeted radiotherapy in the last 3 to 5 years. But again, there hasn't been any systematic study that been conducted on that yet. Now, how about those patients who developed growth hormone deficiency when they were children? And all the international guidelines are quite clear regarding this. Those children or those adults who developed growth hormone deficiency or were found to have growth hormone deficiency when they were children, and the cause of the growth hormone deficiency is idiopathic, so meaning unknown, the cause of growth hormone deficiency was not known at all, and it is isolated growth hormone deficiency, we have to test those patients once they reach the age of full growth, and that is around the age of 16. And why is that? Because we're going to look at this data, those patients with idiopathic isolated growth hormone deficiency when they were children, 35% of them, when they were tested, once they reached the age wherein they achieved the full height already, 35% of those patients will recover the growth hormone axis, meaning they no longer have growth hormone deficiency once they reach the adult years. So it is really important that we retest those patients because we don't want to give growth hormone on those patients who are producing adequate amount of growth hormone, right? So those group of patients need to be tested. How about those patients who had history of traumatic brain injury? This is very contentious because the evidence on this area is very, very poor. But again, international guidelines are quite clear. If we're going to look at the data on patients with traumatic brain injury and the guidelines are saying that we shouldn't be testing those patients who had history of traumatic brain injury within 1 year of the event. And why is that? I want you to look at this graph here, and I want you to concentrate on this part of the graph in here. So this part of the graph showed that if we test the patient either using the gold standard test of ITT or combining two tests, more than one test, ITT plus other tests, that you will diagnose quite a lot of patients with growth hormone deficiency that is represented by the shaded part of this graph in here during the first year. But when this same group of patients were tested again after 1 year of the event, we can see that less than 2% of those patients actually had growth hormone deficiency. The others recover. Because the growth hormone deficiency, most of the patients who had traumatic brain injury would have a transient growth hormone deficiency, which recovers after 12 months. So it's very important that we don't test them within 12 months. We test them 12 months after the event. Okay, so those are the group of patients that we should be testing. So those patients with less than 3 hormone deficiency, those patients who had growth hormone deficiency when they were children, those patients with history of tumor and no treatment was done on the tumor yet because surgery is not indicated yet, and those patients with traumatic brain injury, provided that we don't test them within 1 year of the event. Now, in clinical practice, once we identify the type of patient that we need to be testing, the next thing that we need to be asking ourselves is what test to use, okay? As I mentioned earlier, the first thing is before we even test the patient, we should have a good suspicion that this patient has growth hormone deficiency. And the second one is we test first the IGF-1. The IGF-1 is insulin growth factor 1. So why do we test IGF-1 and not the growth hormone? And the reason for that is because the growth hormone, firstly, is released in the body in pulsatile motion, and it is released in peak when we're asleep. So we cannot technically, as clinicians or nurses, we cannot creep into your house in the middle of you sleeping and then stab you with a needle in the middle of you snoring just for us to test what your growth hormone level is in the middle of your sleep. So that's not possible. And we cannot even admit everyone that we're suspecting growth hormone deficiency in the hospital, so that then we can observe them sleeping in the hospital and then take blood sample when they're asleep. So the growth hormone acts on the liver, and it stimulates the liver to produce IGF-1. And most of the effect of growth hormone is mediated by the IGF-1. And IGF-1 is very stable in the blood, and they have a very long half-life, around 18 hours. So it's stable. So the IGF-1 mirrors almost exactly how much growth hormone your body is producing. And that's what we measure. Again, there's some caveats to that will not be covered in this presentation, because there is some condition that can affect the level of IGF-1. But in general principle, your IGF-1 is a reflection of your growth hormone status. So if your growth hormone is, if your IGF-1, for example, is low already, and you have 3 or more pituitary hormone deficiency, that's enough test. We're not going to proceed with any other tests. If you have 2 or less hormone deficiency, and we're suspecting that you might have growth hormone deficiency and your IGF-1 is either normal or low, and you're symptomatic, then we will have to proceed with a confirmatory test, which is what we call the growth hormone stimulation test. And there are several tests that's been used in clinical practice over the years. And apologies for all these abbreviations, but it is at the bottom of my slide, which you will have access as well through the recording. We don't have time to discuss all these tests. I'm going to discuss to you the 3 that are currently used in clinical practice, because the rest are no longer in use, either because the agent that needed for those tests are no longer available or no longer being manufactured. So I'm going to discuss here the gold standard ITT, which is the insulin tolerance test, the GST, which is the glucagon stimulation test, and the MST, which is the new kid in the block, which is the massimorelin stimulation test. I mentioned to you earlier regarding some of the limitations of the test. It will be ideal if a test to diagnose a disease has very high accuracy. We can reproduce that, meaning we can do that over and over again, and it will give us exactly the same result, that it is safe and well tolerated by patient. That's very, very important. And again, in terms of the health economics, it is inexpensive. And in terms of the resources, it need to be simple to perform. And the agent that we need to use in order to stimulate growth hormone secretion in your body is accessible, meaning we can access that. However, the reality is almost all tests that we use in growth hormone deficiency doesn't meet or hasn't got all these 6 criteria. I'm going to go through that to you one by one. Let's look at insulin tolerance test. This is the gold standard test for diagnosing growth hormone deficiency. Okay. Why is it classed as a gold standard test? I want you to look at this graph in here. So there are 4 graphs in here. Each of these use different types of tests to stimulate growth hormone. A uses ITT. B use a marker called IGHC. And C using IGF-1, and D using another marker called IGF-BP3. I'm going to look at this. The circles that are clear at the center, this circle here, are the normal individual. They don't have growth hormone deficiency. And the shaded circle are the individual with growth hormone deficiency. And we're going to look at all these 4 tests that we use and compare which one can accurately diagnose patients with growth hormone deficiency. Only the ITT showed clearly the difference, or able to differentiate the normal individual. These are the normal individual with high growth hormone level, and those with growth hormone deficiency, those individuals with low growth hormone level. In the shaded circle, there's no overlap. If we're going to look at all the other tests, there are overlap in here. So we don't really know which one is growth hormone deficiency, because these are the growth hormone deficient and these are the normal adults. You can see their overlap within the same level of growth hormone. So that's why the ITT is considered gold standard, because it was the only test that was able to clearly differentiate those patients with growth hormone deficiency. It can also simultaneously assess the hypothalamic axis, meaning the cortisol production in the body through hypoglycemia. It's a very, very good test. However, for this test to be accurate, we need to make the patient unwell. And what does that mean? We need to bring your sugar really, really low. And we need to achieve an adequate hypoglycemia, meaning we need to bring your sugar to less than 2.2 millimoles per liter. And that is more than enough to make you feel unwell. That's why this test is a horrible test. I've never had a patient that I've done insulin tolerant tests who told me I want to have that test again. Yeah, it's a very horrible test. It is contraindicated in patients who are quite old and those with history of heart problem or those with history of epilepsy of seizure. Side effects are very pronounced, and unfortunately, we want the patient to become unwell, because if the patient doesn't become unwell during the test is almost invalid. I know it's quite sad and quite brutal, but that's how the test works. We have to stimulate growth hormone by stressing the patient. That's why it's called an insulin stress test. And stress meaning we need to see that the patient has hypoglycemia, the patient is either sweaty, the patient is either clammy, the patient is either dizzy, or the blood pressure is is going low. It's very resource intensive and it requires a lot of resources, particularly expert clinicians. In some centers in the UK, the reason why they don't do this test is because they don't have the expertise, or they required a doctor to be able to perform or supervise this test. In Birmingham, only our senior specialists can do this test who are prescribers. So there are very few centers able to offer this test because of the resources required to be able to perform this test. So the second alternative test is the glucagon stimulation test. This is a reliable alternative to ITT, but not as good as ITT. It is much more well tolerated by patient. We don't make the patient unwell by doing this test. However, there are some side effects such as nausea, vomiting, and also headache in around 1 up to 3 in every 10 patients who are undergoing this test. Patients are also not allowed to drive after this test because there is a chance of a delayed low blood sugar level. So we always advise the patient not to drive when they're undergoing this test. It is not affected by age or whatever the cause of the growth hormone deficiency. However, this test can overdiagnose growth hormone deficiency. And I'm going to show you this graph in here. So I want you to focus on this graph in here. So these are the patients who were identified as growth hormone deficiency using an ITT. These are the patients that have been identified by glucagon stimulation tests as growth hormone deficient. And we're going to look at this part here and circle here. This group of patients here actually don't have growth hormone deficiency, but if they're going to undergo an ITT or when they underwent ITT, but with the glucagon stimulation test, they were shown to be growth hormone deficient. Well, in fact, they don't have growth hormone deficiency. So around 14% of the patients who undergo growth hormone stimulation test likely don't have growth hormone deficiency. So it is not as accurate, but it's a good alternative. The most important thing is we choose the right group of patients who will undergo this test. There are some patients who are more prone in developing side effects, particularly those patients who are quite old and those patients with heart problem. It's a very long test, which lasts for 4 hours. So it's not a straightforward test that you can just do one blood sample. And the last test I would like to talk to you is a new kid in the block, which is the massimorelin test. Okay, the massimorelin test doesn't require making you unwell because it's a simple test and doesn't involve injection of medication. The insulin tolerance test involves injecting you an insulin through your vein. The glucagon stimulation test involves injecting you with a glucagon into your muscle. However, the massimorelin test only involves you drinking a solution called massimorelin. A very straightforward test. And it is also very quick. It only lasts for around 90 minutes up to 2 hours because you only need 4 blood samples from you. Unlike the insulin test where we have loads and loads of blood samples, and glucagon test, we need more than probably 8 different blood samples for that. For massimorelin test, we only need 4. Baseline, then 45 minutes after you swallow the solution, then at 60 minutes, and then at 90 minutes after you swallow the solution. So very simple test. However, it is not cheap. The massimorelin test costs over 300 pounds compared to 2 pounds of insulin or around 80 pounds of your glucagon, depending on how many glucagon you will be needing. So this is 300 pounds. However, when we are looking at the cost, we need to look at the cost of performing the whole test itself, not just the cost of the agent. So we're going to look at the test, really a quick overview of the tests that we use. If you're going to look at this summary here, not all the tests are in green, meaning not all of them are perfect. So regardless of what you use, there are limitations of those tests, but most of these tests can be used in diagnosing growth hormone deficiency. But the most important thing is we identify the right group of patients, and then we identify the right test for that patient. The next one I'd like to talk about is who we should be treating. Okay, we tested the patient, we know that the patient got growth hormone deficiency, but who we should be treating now. In the UK, there is a strict NICE criteria and NICE guidelines that govern the prescribing of growth hormone to patients. The first criteria is patients should at least be deficient in one pituitary hormone, and that patients should be receiving replacement treatment for that deficiency. So we don't even test any patients if they're not deficient on at least one pituitary hormone, because we're not going to get approval for funding for that. And that's different compared to the other countries in the world. The second criteria is you need to show that you potentially the growth hormone deficiency is impacting your quality of life. So meaning there's an impairment of your quality of life. And you can show that by answering a questionnaire called AGDA, Adult Growth Hormone Deficiency Assessment Questionnaire. It's a 25 question form that simply asks you the question: do you feel tired most of the time? Do you feel grumpy? Do you have poor confidence, so on and so forth? If you score 11 or higher on that, that means that your quality of life is slightly affected by growth hormone deficiency. Not until you meet the first two criteria, number 1 and number 2, that we will subject you to the testing. We will not subject you to testing if you don't meet criteria 1 and 2. Okay. So these are the group of patients that we can be treating with growth hormone deficiency, those who then failed the growth hormone stimulation test. So why do we need to offer treatments? Because we know already that growth hormone deficiency is associated with several clinical sequelae, including increased body weight, increased fat mass, particularly around the belly, reduced muscle strength, poor cardiac function, anxiety and depression, increased cholesterol, and poor energy level. And they also have low mineral bone density. And treatment with growth hormone injection has been proven to improve most of those clinical consequences of growth hormone deficiency. It can improve your cholesterol, it can increase muscle strength, it can improve your quality of life, and improve bone mineral density. So what treatments are currently available? So in the UK, there used to be around 7 or 8 different brands of growth hormone, and the other manufacturers have already pulled out their product in the market because they are not that popular or they're quite expensive. And these are the 4 currently available in adults. So the first one is a Norditropin from Novo Nordisk, and I'm sure some of you are on this brand. The next one is Genotropin. There are 2 types there, the Genotropin Pen and the Mini Quick. And from Pfizer, we have this electronic device, the only electronic device for growth hormone deficiency treatment, which is the Size and Easy Pad from Merck Serono, and the biosimilar Omnitrope SurePal from Sandoz. What are the difference between these? There's no difference in terms of the active agent. So it doesn't matter really what growth hormone you are being prescribed. The difference is in terms of the pen, in terms of the style of the pen, and also in terms of how much finely you can then titrate the dose. Because for Genotropin, for example, the lowest dose you can get is 0.1. But you can get much lower dose than that using your Omnitrope and your Norditropin Flex Pro and also the Sizen. Particularly important on patients who are having quite significant side effect on a slightly higher dose. And the next dose below that would probably not quite enough. So if you prescribe Genotropin, you don't have any option but to go to 0.1, 0.2, 0.3. If 0.3 is too much, but 0.2 is not quite enough, you don't have any option with that for Genotropin. So you better go with Omnitrope, for example, where you can go to 0.25. That is the only difference, really. The second, in terms of the dosing, the second difference is whether you can keep this outside the fridge. Most of the growth hormone devices need to be kept in the fridge to keep their stability and efficacy. The only exception to that is, for example, the Norditropin Flex Pro, where you can keep it at room temperature and also for 21 days. And the size and easy pad, you can keep that at room temperature for 7 days. Auto-injector device, meaning you don't have to push the needle yourself. The only one that has an auto-injector device is the size and easy pad, where you press a button on the device and the machine does the injection for you, and you can't see the needle. Nurse support, depending on the manufacturer, really, and then the nurse support are being reduced now because of the cost of that. But again, they're still available. For norditropin, you have a dedicated nurse paid for by the company who you can ring and give you advice and train you. But most of them have a nurse support. It's not just dedicated. So it's generic from the home care company. So only the norditropin and the EasyPad have a dedicated nurse support where the nurse only deals with growth hormone. For genotropin and omnitrope, you have a nurse support from the home care as well, but they also deal with other treatment. The costs, if you're interested in terms of the costs, I highlighted in red the two most commonly prescribed growth hormone in clinical practice because technically they are the cheapest. Again, I mentioned to you, it doesn't matter whether they're cheap because the active ingredient is exactly the same. So the most important thing is if you need it, that you're prescribed a growth hormone. More hospitals are only allowed to prescribe the omnitrope because they are the cheapest. And if it is not suitable for you because you travel a lot and you need something that outside the fridge, the mini quick from the genotropin is an alternative and the second cheapest. How much does it cost per patient in terms of growth hormone treatment? It depends on the dose. If you're on the lower end of the dose, for example, 0.2 or 0.3 milligram every day, it will probably cost the NHS around 1,500 pounds a year per patient. And if you're on the higher end, around 0.5 to 0.7 or 0.8, that will probably cost the NHS around 3,500 pounds a year. Some patients on a much higher dose, particular dose on estrogen. And this is just a rough estimate of the dose currently based on the BNF price. So what's new about growth hormone treatments? So there are weekly injections that are now available. The first one is the Angela from Pfizer, but this is only licensed in children. The Sogroya from Novo Nordisk, this is both licensed for children and adults. However, even though this is already licensed, we're not using that in clinical practice yet because we don't have confirmation of funding yet from the NICE, so meaning it hasn't been evaluated by the NICE yet whether it is cost effective to offer to patients in the UK. But these can be prescribed privately because it is licensed already, and is being used outside in other countries, particularly in the US. So, but in the UK so far, in adults, we're still sticking with a daily injection. And lastly, I want to talk to you how do we treat patients really, really quickly. So the patient has been tested. We've identified that you are suitable for growth hormone treatment. So when we start you on treatment, we will start you on the lowest possible dose. And the reason for that is we want to make sure that if ever there's going to be side effects, that you don't have that side effects in a big whack. Yeah. And we need to introduce that really slowly because your body has been so used to having very low growth hormone, and all of a sudden we correct that. So starting dose is usually lower in men, between 0.1 to 0.2, and higher in women of 0.2 to 0.3 because of the natural estrogen production. So the estrogen inhibits your liver from producing IGF-1. That's why we need a higher dose in women. And those who are in oral estrogen, you need a much higher dose than just 0.3, anything between 0.3 to 0.5. And then you need to be titrated as soon as you started because we need to increase the dose really regularly every 4 to 6 weeks. And we need to achieve that. We need to target for your IGF-1, which is the one when measuring, to be on the mid to upper end of normal range within 3 to 4 months of starting growth hormone treatment. There's no point in you starting growth hormone and then you're not being titrated for 12 months after starting because you need to feel the effect and you need to be able to know whether it is something that's working for you or not. In the UK as well, we are required to assess your quality of life by asking you to complete the AGDA questionnaire again after 9 months. And you need to show that you've improved your quality of life by 7 points. So meaning from your original score of 11, for example, you need to be scoring 4 or less on your repeat AGDA score questionnaire for you to qualify long-term from growth hormone treatment. If you don't show 7 points improvement in your quality of life score, then your growth hormone treatment would usually not be recommended to be continued long-term. Side effects of growth hormone treatment, like many indications, there are side effects. These are the most common: the carpal tunnel syndrome, pain in your wrist around the thumb. Growth hormone also reduces your body's sensitivity to glucose, so you can develop glucose intolerance, making you prone in developing diabetes. Swelling in your extremities, particularly in your lower extremities and in your joints. And then headache is also reported in some patients. And all these side effects are usually caused by the correction of the sodium and water depletion. When you are growth hormone deficient, your body tends to have a lower salt and lower concentration of fluid, particularly water. And when we give you growth hormone treatment, we correct that. And because of that correction, your body accumulates water again, accumulates salt, and salt retains water. And that's the one that's causing those symptoms initially. They usually improve, and usually we can reduce those side effects by reducing the dose as well. It is important that we optimize your dose really properly, not just leave you on your starting dose without monitoring that. And during the dose monitoring, it's very, very important that we assess as well the side effects to make sure that we adjust the dose accordingly. There's no point in giving a growth hormone that meant to increase your quality of life. Well, in fact, it's causing you more problem. For those women who are on oral estrogen, we always recommend that you consider changing to the transdermal preparation, either the gel or the patch, because it doesn't affect the growth hormone or the IGF-1 release from the liver. You would require less dose, and the chances of you having side effects will be lesser as well compared to when you are on estrogen, oral estrogen, because you will require a higher dose, meaning the chance of side effect will be higher as well. The aim of the dose titration is to bring your IGF-1, as I mentioned, to the middle up to the upper end of normal range without causing any significant side effects. And we should aim that to be achieved within 3 to 6 months of you starting the treatment. And once you are already, the dose is already optimized, what's the long-term monitoring of patients? We should always check for adverse events. If you're having any adverse events every 1 to 2 years, including whether you're still benefiting from treatment, but also if you are injecting. If you're no longer injecting, there's no point in us both wasting the medication and you also going through the series of investigations and monitoring if you're not injecting. So very, very important that we monitor that. We look at the quality of life, particularly when we're considering stopping the treatment or restarting the treatment. Blood pressure, body weight, and BMI, your body mass index, need also to be monitored every 1 to 2 years. And this blood test, thyroid function, IGF-1, your diabetes mark and lipid profile should be checked as well, ideally every 1 to 2 years. For those patients who are on levothyroxine, we also check that during dose titration every 4 to 6 weeks, because patients would require slightly higher dose of levothyroxine during the titration period, because the growth hormone increases the conversion of your T4 to T3. So patient would require slightly adjustment of the levothyroxine. And once they're on optimized dose, it just need to be checked again every 1 to 2 years. Okay, why do we need to see the patients at least every 1 to 2 years once they are established in growth hormone treatment? Because firstly, we need to identify and assess whether the patients still need a growth hormone treatment. We need to assess any comorbidities. For example, if they had cancer, growth hormone is contraindicated in patients with cancer. It cannot cause cancer, but all of us can develop cancer during our lifetime. And if you develop cancer, you need to let your clinicians know, because it's contraindicated in patients with active cancer. And also we need to reduce the dose as you get older. You can see in this graph, this is the natural growth hormone secretion through the years with advancing age. And as you can see in here, as we get older, particularly once you reach 50, 60, and 70, the growth hormone requirement of the body reduces as well. So we need to reduce the growth hormone dose as well as you get older. And it's very important because it is well known that the lower the growth hormone is in advancing age, it is associated with longer life. Yeah. So let's look at briefly, I know can over just briefly in the next 2 minutes, some of the commonly asked questions. one of the most commonly asked questions is, does the growth hormone improve your quality of life when you start treatment? Yes, in majority of the cases. However, this is only seen during the first 1 to 2 years of treatment. And after that, it plateaus. The second is, that's a growth hormone improve body composition, meaning does it reduce the body fat and the waist and hip circumference? Yes, in majority of the cases, particularly in those under the age of 60. Does a growth hormone reduce your cardiovascular risk, the risk of developing heart attack, for example, or high cholesterol, etc.? Yes, in majority of the cases, particularly those under the age of 60. Does the growth hormone improve bone mineral density? Yes, but there's no evidence that that improvement in bone mineral density also prevents you from fracturing your bone. It hasn't been looked at in details. Does it reduce mortality? And one of the most important questions, and the answer to that, I'm afraid, is none of the study have consistently shown that it improved mortality, I'm afraid. Can the growth hormone cause diabetes? Sadly, it's not been, there's something wrong with the slides. The growth hormone can increase the incidence of glucose intolerance, and therefore there's a higher incidence of diabetes in patients receiving growth hormone treatment. Apologies for this. Can growth hormone increase the risk of cancer? Not likely. Highly unlikely it will, and it's been studied quite extensively in the loads of longitudinal studies that didn't show this. However, there is only a theoretical risk. Yeah, because growth hormone, what it does is stimulate growth of cells, but it hasn't been proven. And how long should the patient be on growth hormone treatment? Again, it depends on patient age. There's some study that's showing that at the age of 70, we might, there's no evidence that stopping it could cause harm in any patients. However, it hasn't been studied really extensively, and patients' preference as well need to be taken into consideration. And the last question is the growth hormone still cost effective? Again, in the current day and age, we don't know and hasn't been fully studied. There are so many questions that hasn't been answered in terms of growth hormone treatment, particularly in terms of how long should patient be treated for growth hormone, and what will happen in patient if they decide to stop growth hormone treatment. I have a study that's currently going on that I'm leading in Birmingham. It's called the Gumbel study, aiming to answer these questions. We recruited, this is fully close to recruitment. We're nearing the end of the study already. And what we've done in the study is we recruited patients who've been in growth hormone for more than 5 years, who are willing to stop their treatment. And we also recruited the same number, 25 patients, who continue with growth hormone treatment, and we're comparing them. And we want to see whether those who stop are better off or worse compared to those who are continuing treatment. So watch this space, and hopefully we'll be able to have data here next year. So in my presentation, I've shown you the current guidelines in terms of who we should be assessing for growth hormone deficiency, how we should be testing for growth hormone deficiency, who we should be offering treatment, what treatments are currently available, and how we should be monitoring those patients, and giving you some of the answer to some of the most commonly asked questions. And before I open it for question, I just want to promote our patient event. We do this twice a year in Birmingham. Our next one, it is open to everyone, not just for UHB patient. There's a QR code there. I'm going to leave it here, and so that then you can scan the QR code. You need to register. This is a free event on the 17th of May between 9:30 to 1 o'clock. And thank you very much.
Thanks, Sherwin. That was really informative. What could people expect if they're able to get to that patient open morning in May? Is it talks?
It is a talk. So it's a 2-hour talk. And in this event, we will be focusing on headaches, and we will be focusing, I can't remember on top of my head the topic, we just agreed on the topic last week, but one of the topic is headaches. And I think what happens after surgery. Yeah, how can you make the most after surgery?
Thank you. Thanks so much. That was really informative. We've got quite a lot of engagement in the chat. Some of the questions I think you'll have covered in the talk. I'll